As many people in the world struggle with their adjustment reactions to this virus and this pandemic, we're starting to see that some very bad ideas are beginning to shape what could be even worse policy. Hello, everyone. This is Chris Martinson. I'm here with your SARS-CoV-2 daily update. It's March 26, 2020. This is day 63, titling this one, Bad Ideas Equal Worse Policy. I'll get to that in just a second, but first, the numbers. I'm starting to use the day behind data. Today's March 26th, and I'm using March 25th data. That's because it's all in there and it's complete, and we don't have those gaps and holes that I sometimes had to work around. So taking a look here, we're going to see that Italy is not that far away from overtaking China. Should get there in a day or two at this point in time in terms of total reported cases. Again, China's numbers we know are low, and probably everybody's are low, unless you've got a really exquisite testing program. The only one I would suspect is not all that low is South Korea, because of just how aggressive they've been about it. On this table, of course, I think also Taiwan has done a great job, and Singapore, who, by the way, you will not see on these tables anymore because of how they, I can't fit them on here. They'd be way down at the bottom, many, many rows down, because they've done such a good job containing their particular outbreaks there. Other countries were a little slow to the punch, and of course, when you have an exponential virus like this, an exponential pandemic, every minute counts. And that's why I'm really worried about some bad policy based on some really shoddy thinking. We'll get to that in just a second. So still, you're seeing now many four-digit cases showing up here. The UK recording over 1,000 cases. Switzerland, again, more than 1,000 cases. France, 2,900 cases. Iran, I believe these numbers are low, but we'll take them for now. Germany, many thousands of cases, and again, still with 23. I'm actually finding lots of data now that this is being seriously underreported at this point in time, and because it's really just not even remotely plausible that Germany now has 206 deaths recorded, but only still 23 people in serious or critical condition. So this is that's a bad report right there. That's not even remotely close to right. And now we're starting to see lots of triple-digit increases here in the new deaths on a daily basis column. And, of course, it's just solid red all the way down this whole thing now. And, of course, all of this is going to be moving up in digits. So this will be 4 digits someday, unless we get really appropriate containment policies. And what? How do we solve this thing? Oh, that's right. Everybody wears a face mask. Spain also really struggling here. The United States finally getting its testing up the snuff, recording more than 13,355 cases in a single day. USA is going to move into the number 2 spot very, very shortly. And how did it get there? The don't test, don't tell policy, and pretending as if this didn't apply to us really assured that the United States was going to get there. So how do we make sense of all of this data? We've got here now the total number of cases per 1 million of population. That helps us get our hands around it. But these numbers are hard to really understand because they're all in flight, meaning you could test somebody here and they could show up over here in the new case column, but it might not be for 10 or 11 days before they show over here in your serious critical case. It might be a month or more before they show up in your recovered case, because didn't make it on here, but the Diamond Princess still has, I think, 15 cases that are unresolved, and it's been well over a month and a half now since some of those cases first popped up. So it's all in flight. So, what's the right thing to divide by something else to get a sense of where this is? There is no right way to really get an absolute, for sure, final case fatality rate or some other indicative measure like that until all is said and done and the last case is resolved. But until then, what do you do? Here's one way to look at it. And here we're going to look at just 2 columns, which is deaths and then recovered. So there's only 2 ways that this will resolve once you become a case. You either die from it or you recover from it. And then it's called resolved. Right here, we see that. So this too is not, don't take these numbers as anything other than indicative and directional, because if a country has just started to get its very first sets of cases, it's going to be very low on the recovered side. So we're dividing by a very, very low number. So when we look at, and resolved here would be deaths plus recovered. So in this case, you would have 356 divided by 356 plus 3. And that gives you a number of 99.2%. Is that the resolution rate? No. But when you start moving down this and you start seeing countries that have been at this quite a while, you're starting to get closer to reality. It's concerning to see that Italy's number here is 44.5%. China's number is still 4.3%. Again, I don't believe their numbers on either the numerator or the denominator side. I don't believe either one of these two bits right here. Okay. But we're starting to see, that there's very high numbers in here. And I'm not sure about the Diamond Princess yet. We'll have to see if that is actually truly indicative. But remember, these people all got best-in-class world care. So that might be the best we could hope for. And that's if and only if we'll let resolve out at 1.6% if we don't get any more deaths out of the 15 remaining serious critical cases. All right. But this just gives sort of a sense of where we're at. And that's why it's really horrifying, because when you get into the hospital settings and you have numbers like these, very, very upsetting. And of course, that can overwhelm your hospital system. Again, here, still exponential. We have, as of March 25th, 389,750 ex-China cases. Maybe this line's easier to see than that red one I've been drawing. Drew a yellow line in there. And you can see that this is tracking perfectly flat, all of these little blue balls in here. So a flat line on an exponential chart means you have an or on a log chart means you have an exponential function going on. That's what a flat line means. And from this as well, we can see that we are also on track for about the slope of this line right here. Gives us about 14 days or so to get a 10-fold increase. So to go from 10,000 to 100,000, from 100,000 to a million, from a million to 10 million. That's the trajectory we're on, about every 14 days. All right, from Stanfield Ken here at Twitter. Here he's looking at the total active by the total cases. So this just gives you a sense of where you are in this, because if your total active divided by total cases, as in Norway, look at this, 99.4%, nearly all of their cases are actually currently active, right? China has resolved nearly all of its cases. So it's all the way down here at the bottom because there's very few active cases divided by the total cases they had. Eventually, after this whole thing is done, everybody goes to zero, right? There's no more active cases, and that's just where you end up. But this just tells you how early we are in this particular cycle for all of these countries, right? So when you're way up here in the 90s, 80s and 90s, you have a long way to go, and you can expect things like your deaths and your serious cases all to climb as a consequence, because, again, it takes time from the moment of first appearance of a symptom. It takes about 7 to 8 days to show up at the hospital. It might be another 4 or 5 days after that before you tip into the more critical side of things, and then it might be 2 or 3 weeks in the hospital in order to try and recover from that. So this is just a chart that says we got a long way to go yet in this story. First, second innings for some of these countries up here. Not the flu. When we look here at the total critical divided by total cases, so how many people out of your total identified cases are showing up as critical? So this isn't just serious, this is critical. Here we're seeing what the numbers look like, and they're very high. So if the global average is 3.2%, these countries up here are showing it at a very, very high critical rate. And these countries down here might expect to move out a little bit because it takes time for some of them, right, for these cases to come out. Like if you just recently started down this path, like Germany here, that's a wrong number for Germany. That just doesn't make any sense at all. But if you've just started to have an infection outbreak in your country, it's going to take time, a couple of weeks minimum, before you really start to see that flood of critical patients into the hospital, again, because of the time lag involved in this. Again, how do we beat this thing? It's not that hard. Here is a very simple solution to a complex problem. Everybody wears a mask. That's it. Everybody wears a mask. Need to hear it again? Everybody wears a mask. There. That's how we beat this thing. It's really not that hard, and I'm really astonished at how much time is being spent attempting to figure out how to give money to everybody and how to prop the economy and how to get stocks going back up again. And there's all this effort to basically try and wag the dog rather than to just do what's the simplest thing is. Where's our face masks? Where's our policy around everybody wearing face masks? Now, the Czech Republic, I remember I mentioned that yesterday, and I've seen some more data that they moved from basically nobody to everybody wearing masks in 10 days. And it was from the bottom up, and the people all went for it. And guess what? They are very much in the process of crushing their case count over there. So that's how it goes. All right, relax already. This one where I talked about where leaders are arguing about, are they going to save lives or the economy? Again, without bothering to tell us where we are on the face mask thing, because just tell us. What's the plan? How are you going to manufacture them? And how are you going to get everybody wearing them? That's the way you get through this. But this one struck a nerve. Kim here writes, Chris, I think you've gotten quite arrogant in your coverage of this crisis. You report like you are the only one that knows the correct answer, as if there is one. You may want to back off on what you believe. Just report what's happening. This is a financial crisis. So Kim, very unhappy with the way I characterized this particular episode here. MC here, same thing. But next time, don't double down on your beliefs. I'm not really clear what's going on. I do have beliefs, I guess, around the economy. And I believe that corporations that ran themselves foolishly really ought not to be bailed out. And that's a strong belief. And I, for one, wouldn't mind if a large corporation went away because they ran themselves poorly, because you know what will happen real soon in a capitalist or true capitalist society? A better company will come along and replace that and fill the void. And that's how that's supposed to work. At any rate, the relax already crowd, this is their logic as far as I can tell. Run, Godzilla's attacking the city. Relax. He's only killed 4,000 people. The flu kills over 25,000 every year, right? That's pretty much how I see this at this point. So a little humor injected, because I guess we need humor at this point. That's where we are. When you hit the boom stage, Scott Gottlieb here writes about an imprecise but nonetheless troubling indicator. Last night, EMS in New York took 6,406 medical 911 calls, the highest volume ever, surpassing 9/11 2001. Thank you, Jeff, for pointing that out to me and forwarding that. So, that's what happens when you hit the boom stage, and almost certainly we're going to see that record get eclipsed day after day as we go forward. All right, now I'm going to get into something. This is really important, because now we're down to bad logic, bad thinking leading to bad policies, and this is where it gets dangerous. So I want to, for those of you who can manage the logic of all of this, that's why you're here. That's why you're listening to this. You can hear what basic logic is and come at this without your belief systems interfering with your interpretation and ability to hear this. So congratulations. Thank you for being here. We're a small tribe, not that small based by the viewer count here, but an important tribe, because honestly, we need more logic and more rational thought about all of this stuff. We can be passionate, and I'm not saying be unemotional, but let's use our logic where we can as much as possible. Now, I highlighted this one yesterday. This was an opinion piece, and this was by a couple of professors out of Stanford. And I'm going to highlight a couple of slightly different paragraphs from this opinion piece here. This came out on March 24th. And here we go. Quote, fear of COVID-19 is based on its high estimated case fatality rate. 2 to 4% of people with confirmed COVID-19 have died, according to WHO and others. So if 100 million Americans ultimately get the disease, 2 million to 4 million could die. We believe that estimate's deeply flawed. The true fatality rate is the portion of those infected who die, not deaths from identified positive cases. All right, this is really critical, and we're going to have to dive into this just a little bit, because there's a really important case to be made here. The latter rate is misleading because of selection bias in testing. So the latter rate of how many people are dying up here. And the bias in testing, the degree of bias is uncertain because available data are limited. But it could make the difference between an epidemic that kills 20,000 and one that kills 2 million. Remember that number 20,000? It's starting to pop up. I've seen it in two critical places, but just for some reason, 20,000, that seems to be the number. Just remember that. We'll get back to it. If the number of actual infections is much larger than the number of cases, orders of magnitude larger, then the true fatality rate is much lower as well. That's not only plausible, but likely based on what we know so far. So those are really big claims that they're making right there. How can we reconcile these estimates with the epidemiological models? Well, first, the test used to identify cases doesn't catch people who were infected and recovered. Okay, that's part one. So let's say you catch this thing. if they swabbed your nasal passages, they would find it in a PCR test. But, then you recovered and you don't have it in you anymore. So you are walking around, you're immune. You're actually part of the herd immunity now. You've got circulating antibodies, but you no longer test positive for this. That's first thing that they're resting on. So I'm going to take that apart in just a second. All right. Second, testing rates were woefully low for a long time and typically reserved for the severely ill. That's true. Together, these facts imply the confirmed cases are likely orders of magnitude less than the true number of infections. Okay, that's bad logic. Together, they don't imply orders of magnitude, right? So I don't know that they imply that at all. You'd have to make a case for why you think orders of magnitude. So orders of magnitude is plural, so it's at least 100-fold off. They're saying if we have 1,000 people who've testing positive, at least 100,000 are actually truly infected, all right? Epidemiological modelers haven't adequately adapted their estimates to account for these factors. So that's the argument, and we have to burrow into it because this argument is starting to show up and influence policy, and mostly because I think policy wants to be influenced in this way and say, this isn't so bad. It's not so bad. All right, let's talk about this now. So the real argument here is a numerator versus a denominator issue. So what are the issues? So deaths are up here in the numerator, divided by total cases. Deaths divided by total cases would give you your case fatality rate. So what are some problems with the numerator? First, these are all the deaths that are not counted. You might have somebody die who wasn't tested. So they just died, and we can't assign that they died from the coronavirus. Could be for political reasons. I think China has very strongly said that and communicated that they're not willing to count deaths. I think Iran falls into that. I think there are a variety of countries that for political reasons aren't reporting these, and I understand what those reasons are. Or it's a misdiagnosis. Somebody comes in, you're not sure what they've got, and they don't actually get diagnosed, or it's a misdiagnosis, and they die. And then they can't be recorded as having died from coronavirus. So if deaths aren't counted, that's going to make the case fatality rate seem too low compared to what it actually is, because this is too low. But also, this could be too low here because actual cases are undercounted. Insufficient test kits, yep, that's absolutely the case. The don't test, don't tell policies drove that number down, right? And sometimes we've heard people begging to be tested, and they can't get tested, mostly because there aren't test kits, but also because in many cases, the corporations involved or the politics involved don't want to know. And so this has been an active policy of many countries and as well many corporations. Asymptomatic or maybe too mild to present even for testing. So it's possible, and as hypothesized, surmised in the above article here, that maybe some people actually have gotten this thing, but they didn't have any symptoms at all, but yet they still have herd and circulating antibody immunity, or they were just too mild, they didn't present, they had the sniffles, they didn't even know they had it. It's always possible. So in one case, these are the arguments for why this would be low, and here's some arguments for why this would be low. And the debate is this much, much lower, right? And so they're saying orders of magnitude. So in this article, they are surmising that this might be 100 or maybe more, because it's orders. Maybe they mean 1,000x too low, right? And if that's the case, then that's going to make the case fatality rate way too high. All right. And just to show you how the numerator can be off, this just came in from Twitter this morning to Bergamo. From the 1st to the 24th of March, the deaths of residents were 446. 348 more than the average in recent years, which was 98. Deaths officially due to COVID-19 are 136 in the period here. There are 212 more deaths than that happening. So 348 is 212 more than 136. So it means, that for whatever reasons, more than about 60% of the extra deaths that are happening in Bergamo weren't recorded as being due to COVID-19. So the numerator is way off. But also they're saying here with a mortality of 1.5 to 2%, if you assume that, the infected in the city would actually be between 17 and 23,000, which would mean this was too low. So one of these things is wrong. Either this is wrong, or this is wrong, or the case mortality rate is wrong, the case fatality rate, one thing or another. So this leads to the thorny data issue, and we got to talk about it. So there's two scenarios we're going to consider here, because this is really what the battle comes down to. Is scenario A correct or scenario B correct? So this is just a schematic model here. The white circles here are uninfected people. The blues are going to stand for infected but unknown. So they're asymptomatic, they're untested, they're out there. They just aren't showing up in the official case statistics because they are undetected for some reason. And red is infected and known, so they've been tested and or declared, because you can, with a good CT scan with a ground glass opacities, you might just say, that person's got it. All right. In scenario A, you can see here that, there's a number of undetected people. I think that's absolutely the case. And we have infected known people. And then the argument then is going to be, well, how many of these white dots are actually out there? So scenario A is the one I think we need to operate under, but that's my opinion. Scenario B is what these people and many others are starting to argue for. They're saying, oh, no, we've already, it's already swept through. Most people have been exposed to it, more than half, whatever the numbers are. And so there's actually the incidence of this is actually much higher than you might suspect. So let's see what this would resolve into. Let's take scenario A. If you add up all of these dots, you find out that there's 11 red dots and there's 20 blue dots. So there's 11 infected known, but there's 20 that are infected and unknown. So that means there's 100 dots total on each of these sides. So that means there's an 11% apparent incidence, so you would take your cases in the population and say, we have 11% incidence. But the true incidence or actual incidence is 31% because it's 20 plus 11. It's both of those. It's 31 out of 100. So you actually have a 31% actual incidence. So let's suppose out of these 100, you had one death. Well, your apparent case fatality rate is going to be 9.1% because that's 1 divided by 11. But the true or actual case fatality rate would be 1 divided by 31, which is only 3.2%. So that's the argument, is saying we're seeing these case fatality rates that seem to be high, but the truth is, according to the people in these sorts of arguments, is there's actually many, many more blue dots in this than you would suspect. All right, let's run the other scenario. In scenario B, take a quick peek. There's 5 red dots in here. Oops, 1, 2, 3, 4. There's actually only 4, so my numbers are off. Let's pretend there's 5. 5 red dots, and then 79 blue dots. So that would have given us a 5% apparent incidence, but we actually had an 84% actual incidence, which would be 5 plus 79. And then let's suppose one death. Well, 1 divided by 5 would have given us a horrific 20% apparent case fatality rate. But in truth, it would have been a 1.2% actual case fatality rate, because that's 1 divided by 84. Okay, so that's how that all plays out. In scenario A, these numbers they're apart from each other, but not that bad. But in scenario B, they're really far apart, and you could make some huge policy errors if scenario B was correct, but you were thinking that scenario A was correct. So where's the truth in this story? Well, luckily we can use some logic to sort of figure out where we are. Is it true that many, many, many more people have actually been infected? Or is it true that actually not that many people have been affected because we're at the early stages of this thing romping through our populations? All right. I'm going to have to build a case here. It's going to take me a couple slides, but I'm going to use the UK as an example. So here I'm using, this is from the European Center for Disease Control. And here we're going to make a case for support for scenario A. So first up, here's something we know. Here they're asking the question, what is the duration of SARS-CoV-2 virus shedding in bodily fluids of symptomatic patients after remission of symptoms? So here's something we need to know. First, SARS-CoV-2 virus can initially be detected 1 to 2 days prior to symptom onset in upper respiratory tract samples. And so if that's where we're sampling and we're doing those nasal swabs that go way deep up, looks painful to me, or at least uncomfortable, then let's just go with this data. 1 to 2 days prior, and the virus can persist for 7 to 12 days, in moderate cases up to 2 weeks in severe cases, okay? In feces, viral RNA has been detected up to 30% of patients from day 5 after onset, up to 4 to 5 weeks in moderate cases. Okay? So 4 to 5 weeks. So there's still viral shedding going on. Prolonged viral shedding from nasopharyngeal aspirates up to at least 24 days after symptom onset was reported among COVID-19 patients in Singapore. And researchers in Germany also said the same thing. And prolonged virus shedding has been observed among convalescent children after mild infections in respiratory tract samples 22 days. All right? And feces between 2 weeks and a month. So there's... they said here 1 to 2 days, but there's I would think that you've got at least a week of detectable virus in based on the Singapore data that I saw before. But even let's just imagine this is 1 day. It doesn't really change what I'm saying. But you've got probably virus here you can detect through PCR a week during the asymptomatic phase, maybe just a few days, at least 2 weeks during the symptomatic phase, right? And at least 1 to 3 weeks post-symptomatic. And this could actually be up to 4 weeks, right? What did they say? Yeah, 4 to 5 weeks in moderate cases. So at any rate, we've got somewhere between 4 and 7 weeks, okay, or 28 to 49 days of detectable viral shedding. Because remember, these people up here were saying, first, the test used to identify cases doesn't catch people who were infected and recovered. But what the argument I'm starting to build towards here is that could take a long time. That could take 4 to 7 weeks for somebody to have gotten it, but no longer be detectable. Okay, so they would escape your detection. So let me continue to build the case and note that the doubling time in the UK is 3 days, almost perfectly, right? Here's the UK. This is a doubling time of every 2 days. This is every 3 days. This is 5 days. And this is every 10 days down here with Singapore, Kuwait, those people. All right, so let's look at the support for the scenario A. Let's look at UK timing. I highlighted this as well. I think this is a very dangerous study. I think it's shaping policy. So this came out on March 24th, and this assertion here was coronavirus may have infected half of UK population, right? And the new coronavirus may have already infected far more people in the UK than scientists had previously estimated, perhaps as much as half the population, according to modeling by researchers at the University of Oxford. Okay, well, if that's the case, then they're almost all the way to herd immunity, and there's no problem, and let's just forget about it. And our hospitals barely got overrun; it wasn't a big deal. That's the whole implication of all this. All right. If the results are confirmed, they imply that fewer than 1 in 1,000 of those infected with COVID-19 become ill enough to need hospital treatment, said Sunetra Gupta, professor of theoretical epidemiology who led the study. The vast majority develop very mild symptoms or none at all. So how would you go about knowing if that was true? Well, one thing is you could begin large-scale serological surveys. That's antibody testing. So you would only do that if it turned out somebody had gotten it all the way and had recovered, and you needed to look for circulating antibodies because they didn't have viral loads anymore. But again, that's going to be a minimum of 4 weeks to 7 weeks after they've caught it. Okay, so that's the first thing to notice. Okay, so let's look at this study now, and let me just talk about something. So in this thing, they said right here, they thought that that COVID-19 had actually started to move into the population in mid-January, according to the study. They said, well, maybe people, it moved in mid-January. Most people got it, and now they've gotten over it. So let's remember our exponentials here. This is an exponential model right here. We're doubling this every 3 days. Because, why? Because that's how long it's been doubling for a long time in the UK, every 3 days. So let's imagine we started with right in mid-January with 50 cases. It doubled to 100, then 200, then 400, 800, 1600, and so on. And we're just marking the days here, and this would be the actual dates that would correspond with that. And so the idea here would be that sometime around the middle of March, when they were talking about this, let's call that right around here, they would say half the UK population had already been infected. So that would be basically that number, because UK population is around 66 million or so. So somewhere in here, they would say half the population has already been infected. Now, here's the deal. This bar represents four weeks of time. Slide it mentally, visually, anywhere you want on this thing, right? But let's imagine now that we have to go back just 4 weeks. Just 4 weeks, and because anybody who was infected more than 4 weeks ago, we probably can't detect with a PCR test, right? That's the logic, right? But notice something about doublings. Here's the fun thing about doublings. With each doubling, as many people are added in that next doubling has accumulated in every prior doubling before that point in time. So we went from 26 to 52, but it took all of this time to get to 26 in the first place. And then we go from 52 to 104. Just in that next 3-day doubling, as many people are added in that single doubling as were added in all the prior doublings before that. That's the nature of doublings and exponentials. Pretty cool, right? That's an interesting thing to know. And so what this means is that to rest on the argument that we need serological testing because so many people must have already gotten this and gotten over it that we can't detect them by PCR testing is to make this argument, is to say we have to go back 4 weeks from this. Let's say 4 weeks is back here, okay, from the 15th of March back to the 15th of February. So they're saying that because there's 52 million people infected now, and 4 weeks ago there were 51,000 people, these 51,000 may well have already recovered and no longer have circulating antibodies, okay? But we're trying to detect those 51,000 who are already cured and recovered, and we're comparing that against a total sample size of over 52 million. So this is a really dumb idea because it doesn't understand that when you have an exponential function like this, almost everybody that is going to be absolutely sporting viral loads that you will detect. Why? Because almost all of them were infected in just the past 2 doublings, right? I hope that all makes sense. So, dumb idea on that one, right? And that's the same idea that these people were coming forward with. First, the test used to identify cases doesn't catch people who are infected and recovered. Hey, there's 100,000 people who've already, what if 1 million people caught this? Well, that's just totally ignorant of how this actually works. And when you have a 3-day doubling time, you're not going to miss them because the only people you can miss were way back here, right? And so it's actually not a logical argument. Here's the second thing we can throw on top of that then. South Korea has done the most elaborate testing, and so we're looking here at the number of COVID-19 cases confirmed. They ran 364,000 total tests. 341,000 were negative. 9,241 were confirmed positive. So if this thing behaves the same in South Korea as it does here in the UK, and you have South Korea running very, very aggressive testing, and you had a huge prevalence because this thing just sweeps through the populations, and it's a scenario B, right? It really sweeps through, and what did they say here? More than half the population's already infected. Then you would expect to see here, lots and lots of cases. You would expect to see, half of these cases showing up positive, and you would say that very few of them were serious, and that's what you would expect to see. But now these people are going to have to make a different argument, which is, well, maybe these people get infected by it, but they don't actually create any virus particles. They're going to have to get crazy on this whole thing. All right. So the support for scenario A here is that says we're actually here is based on just some simple logic that says, okay, that's dumb to think that you could actually have a lot of infected people that you can't somehow detect because they were too long ago to detect and they've gotten over it and there's no longer any circulating virus shedding going on that you can detect. And the second thing that's dumb is looking at all of the particular cases that we have, such as the testing that came out of that the town of Vo in Italy, out of South Korea, out of Taiwan's extensive testing, out of Singapore's extensive testing. All of them look like this. You run lots and lots of tests, and you find that it has a fairly low incidence in your overall population. So what's in support of scenario B, though? What else do we have that might support that? Well, you have this really high R0, and that does suggest that there are many more cases than officially stated. So I am very positive, very comfortable telling you that the denominator is actually a lot larger than we currently know. But is it orders of magnitude larger? This data says no. But I do know that it is larger. So let's go with that. As well, there's poor testing in many, but not all countries, right? So The denominator is going to be a lot larger in the United States, which had a very, very shoddy, poorly run, don't tell policy, or maybe it was a well-run policy of that, but bad policy. All right. But in the places that have really good testing, nothing supports scenario B. So we can just say testing has shown scenario B to be true. Not yet. There's no testing to support this. Just what do we have in support of it? Well, we have some researchers at Stanford surmising it to be true. We got some UK modelers assuming it to be the case. And we have all the slow adjusters out there who want it to be true. But we really don't have any solid data for this yet. All right. So here's the what if around this. What if we choose to act as if scenario A is correct, but we're wrong, and scenario B is correct? So scenario A, what happens if we assume this is true, that there's some, but not that many uninfected unknowns compared to all the white dots? There's still many, many more uninfected people who can be infected. What if we assume that's true, but actually this is the case? It's really swept through the population. We just failed to detect it. We missed it. What happens if we're wrong? Well, jobs are lost. Sure. Yep. The economy takes an unnecessary hit. That's what happens here. However, this all could be managed and minimized with face masks for everyone. And if we did a surgical application of stay-at-home rules so that, the most likely to be negatively impacted stay home and the young and the healthy go out to work. But that's what happens if we choose to act as if scenario A is correct and we're wrong, but scenario B is correct. What if we reverse that? What if we choose to act as if scenario B is correct, but we're wrong, and scenario A is correct? Well, under that circumstance, the hospital system is completely overwhelmed. Thousands, possibly millions of SARS-CoV-2 patients die unnecessarily. Thousands of collateral damage patients die unnecessarily. These are heart attack patients who don't get treated in time. These are all the other reasons that people show up in hospitals needing surgery, needing emergency care that can't be attended to properly because the hospitals are swamped, your healthcare system's overrun, and it's collapsed. So you get lots more collateral damage. Lots of people die, thousands, hundreds of thousands, maybe millions. And you know what? The economy tanks anyway. So if you said, which would you logically say you would you want to make this error or would you want to make this error? To me, there's no question about this. It couldn't be a simpler choice. This is the error you would always want to make, because if you make this error, you still make this error. You still lose jobs and the economy takes a massive toll tanking anyway, right? Plus you have all of those unnecessary deaths. So to me, not even a choice. All right. And, I said that this is a great and serious and deadly serious debate, and it's coming out a lot. Now, look at this in March 25th. This is Neil Ferguson. We highlighted him, many, many weeks ago. And ironically, he also came down with COVID-19. And now he's changed his tune a little bit here. And he's saying now that the UK has enough intensive care units for coronavirus. Expert predicts, there's your expert. The UK should now be able to cope with the spread of COVID-19 virus, according to one of the epidemiologists advising the government. Neil Ferguson at Imperial College London gave evidence today to the UK Parliamentary Select Committee on Science and Technology as part of an inquiry. He said the expected increases in National Health Service capacity and ongoing restrictions to people's movement make him reasonably confident the health service can cope when the predicted peak of the epidemic arrives in 2 to 3 weeks. UK deaths from the disease are now unlikely to exceed 20,000, he said. Here's that 20,000 number again. I'm feeling like some sort of focus group came out. I'm a little suspicious that the UK is thinking 20,000 and we got Stanford researchers proposing 20,000 for the US. That just doesn't make sense to me. All right. Continuing this, it says new data from the rest of Europe suggests that the outbreak is running faster than expected, said Ferguson. As a result, epidemiologists have revised their estimate of the R0. This measure of how many people other people a carrier usually infects is now believed to be just over 3, he said, up from 2.5. That adds more evidence to support the more intensive social distancing measures. That's true. That's good. That's okay. Most importantly, it assumes that most people who contract the virus don't show any symptoms and that very few need to go to the hospital. So, I guess I should say that was because of this University of Oxford study. Sorry, I jumped the gun. I should have read through this. This University of Oxford study said that, maybe half the population could have been infected. But that has to assume that most people who contract the virus don't show symptoms and very few need to go to the hospital. I don't think that's consistent with the observed data, he said. Okay? But when you believe in scenario B, you get stuff like this. Patient capital 17 brought this to my attention. I'm now feeling waves of anger and confusion. How is this even possible? What's possible here? Well, COVID-19 is no longer considered to be a high consequence infectious disease in the UK. That can't be true. That's nuts. Oh, it's true. Here you can see the URL for this. As of 19th March 2020, COVID-19 is no longer considered to be a high consequence infectious disease. The Four Nations Public Health Group made an interim recommendation in January to classify COVID as a HCID. This was based on consideration of criteria about the virus and the disease with information available during the early stages of the outbreak. Now that more is known about COVID-19, the public health bodies in the UK have reviewed the most up-to-date information against the UK HCID criteria. They have determined that several features have now changed. In particular, more information is available about mortality rates, low overall. And there is now greater clinical awareness and a specific and sensitive laboratory test, the availability of which continues to increase. That doesn't change anything. So yeah, the COVID-19 has been downgraded a bit in no small measure because you had things like this Oxford study, alleged study. It's not even a study. It's just a model coming out and making these wild assertions which aren't supported by either logic or the current data. Remember, there's only one way to beat this thing anyway. It's very simple. This is a simple solution to a complex problem. You just wear a mask. Everybody wears a mask. I also want to keep reinforcing, you really should think about planting a garden. Even if it's in buckets or whatever you need to do, just plant it. All right, conclusions for today. There's a really highly emotional and it's a not terribly logical argument going around in support of scenario B, which is a high endemic prevalence. So scenario B says lots of people already have this. It's not a big deal. Because so many people have already had it and are asymptomatic or low symptomatic, that means that the case fatality rate's really a lot lower than we thought. It means that, the serious complication rate's a lot lower than we thought. It means a lot of things. Unfortunately, all the data coming out about collapsed hospital systems and the absolute virulence of this thing don't support any of that stuff. But guess what? A lot of people want to believe it. And so that's what we're seeing show up. And by the way, it seems to be shaping policy. Going to get back to work in the United States. It looks like the UK is relaxing things a little bit, and it's going to lead to some pretty bad outcomes. It's really not supported either by logic, right? The logic of you ought to really be able to test people and detect it. If this is true, they should be showing up in the test kits because most of them got infected just in the last 6 days, right? And we don't see it in the data anywhere. So it's not supported by logic or the data that we've got. It might be true. It's always possible. But if not, then the consequences of any policy stutters or redirects based on it are going to be really awful. So that's how I see it at this point in time. I'm willing to revise this when new data comes in. I think that we're really shaping up to have a bad number of weeks here. And because of faulty logic and faulty models like this, it's going to be worse than it needs to be. And when I say policy stutters, I'm talking about leaders confused by these sorts of big decisions they have to make and seemingly countervailing data by authoritative people, but it's bad logic. And because of that, we get those hesitations, and you can't hesitate with a fast-moving coronavirus like this. All right. Remember, it didn't have to be this way. And the corollary to that is I'm really excited for the future where we can do better, and we will do better. Thank you for listening.
Hi folks, Adam Taggart here. Chris Martinson and I are the co-founders of Peak Prosperity. If you want to get alerted whenever we release a new video from Chris, just click the red subscribe button right beneath the YouTube video player. Once you've done that, a little bell icon will appear right next to it. Click on that bell. It looks like this. And that's it. The next time we publish a video from Chris, you'll immediately receive a notification from YouTube. Thanks for watching our videos.